Hi, I'm Ruth Werner, and this is my audiovisual sidebar to go along with my Pathology Perspectives column about endangerment sites. And I am really happy to welcome my friend and colleague, Whitney Lowe from the Academy of Clinical Massage. So thank you, Whitney, very much for joining me today.
Absolutely. Happy to be here with you. Always happy to chat with you.
Oh, thanks. I appreciate that. And I will just give a heads up that Whitney has a bird loose in the room. That's Ladybug.
That's
So
right.
if we hear any input from Ladybug, then that's what that noise will be.
Yeah.
So Whitney, what year did you go to massage school?
Started massage school in 1987.
Oh, so I'm actually ahead of you a little bit because
Yeah.
I started in late '83, and
Yeah,
I'm
I think
always,
we decided that. Yep.
yeah, always fond of saying way back when
That's
I
right.
was in massage school.
When we had stone tablets and that kind of thing for our learning materials.
um, So I'm wondering what you remember about your education about endangerment sites.
Well, the first thing that I remember is that we didn't call them endangerment sites. The crux of it was I remember getting a sheet of paper that said contraindications on it, and it was a list of places not to work. It seems like that term of endangerment sites creeped into our lexicon a number of years later. So basically, the way we were taught, these were just contraindications, don't work here, don't work there kinds of things, without any really good explanations of why or under what circumstances would you not do these things. So it
Oh,
was
that's
pretty
really,
simple. Yeah.
yeah. And that word contraindications is thrown around a lot, and it means a lot of different things. So
Yeah.
in your context, it just meant areas not to. Did you learn don't touch here, or did you learn more nuance about that?
It was pretty much don't touch here, don't do anything here. And, the places where obviously nuance was needed, because there's certainly things that you could do in those regions. But, at that point, there was a lot of erring on the side of extreme caution, because I
Hmm.
think we didn't know so much. So there was an effort to really try to just cover all the bases and make sure there was not going to be any liability issues from improper things that people just didn't know enough about.
Yeah, and then the upshot of that is that lots and lots of clients miss out on maybe some really important body work because their therapist feels that they're not allowed to touch them, near the axilla or
Yeah.
in
Yeah.
the belly or lots of places.
And then
Um,
also, what comes off of that as well is a fair amount of confusion for a lot of therapists when they go to an advanced continuing education course, and all of a sudden you're treating the subscapularis and the axilla. It's like, wait a minute, I thought we weren't supposed to touch anything around here. So that does create a fair amount of confusion there as well.
yeah, and so as a person who teaches advanced um, bodywork techniques, do you find still that you are having to sort of unteach a lot of things that people walk in with?
Yeah, and I would say there's some degree of unteaching and some degree of just settling down apprehension, because what's more is actually probably less unteaching and more of like, I thought we weren't supposed to touch anything there, so they're really apprehensive of doing anything at all. So
Hmm.
to
Hmm.
try to teach them how to do what we're doing with a sense of both compassion, care, and competence, and doing it appropriately, they find a greater degree of apprehension and uncertainty around what they're doing oftentimes.
Yeah, that's interesting. And speaking from the perspective of both a pathology educator and someone who serves as consultant or expert witness in litigation cases where massage therapists may have injured a client, um, I see some value in that apprehension. That doesn't mean I want people to be afraid of working, but I want for people to know that to work safely in some areas of the body, they really need an advanced level of education.
Yeah. And I don't know if this has been your experience with your litigation cases, but I would say a fair percentage of the litigation cases that I've worked on did not involve people doing things inappropriately in an endangerment site. It
Hmm.
involved people doing things inappropriately in normal places that would not necessarily be considered endangerment sites, but the way in which they were working might have been careless or not appropriate.
Yeah, it happens that the cases I've worked with have mostly been places where really people were doing advanced work that they didn't have the education to do.
Yeah.
Um, I am really interested, when I was sort of brushing off the concept of endangerment sites, which was the term that I got when I went to massage school. When I was sort of brushing that off to see what's being taught now and to see what actually shows up in the medical literature, which is going to be only a tiny, tiny portion of examples of when massage therapy might have caused an injury. I'm curious about some of the folklore that we learned about things that are safe or not safe to do. And I have some ideas about some of that from my own perspective, but I'm curious if there are sort of traditions about working safely that you have had some interest in pushing back on.
Yeah, well, I think there's a number of things that would have traditionally maybe been endangerment sites or ways of working that people said don't do this kind of stuff, and they do involve saying like, well, I think there's some ways in which you could do really effective work in here and just be careful about what you're doing and do things a certain type of way. I mean, a good example is, potentially the, problematic areas that might be behind the knee in the popliteal fossa, for example. And there seems to be some significant benefits on things like lymphatic drainage that would be done directly in that area for a particular type of problem. And so the issue becomes, it's not so much a blanket statement as it is one that involves some deeper clinical reasoning about what type of thing and why are you doing that particular type of thing in that particular area, as to whether or not that's really an endangerment site that should be left alone or only done with certain types of things.
Yeah, my take on endangerment areas in general, like the popliteal fossa or the anterior neck, is yes, of course we can touch here. We have to touch here with extra conscientiousness. And the gorgeous thing about manual lymphatic drainage is that unless someone has an infection, you're really unlikely to do any damage. And at the same time, it is so profoundly relaxing that we could do lots of good things. But I'm interested in, for instance, I learned that really you can only on the extremities work from distal to proximal. Because if you go the other way, you're going to damage veins.
Right.
And I don't know that that's true.
Yeah,
and we've been at this is sort of culturally ingrained to me in such a way that if someone went with some force from proximal to distal, particularly on my legs, I would feel really uncomfortable about that because it's ingrained in me. But I'm wondering if that's always the case.
Yeah, well, I think it's one of those situations where at least the research that has been done to this point has not really supported that idea. And it is something that, you can clearly see where it came from. It's an application of our understanding of how venous return works and how the valve systems work. And I can clearly understand how somebody may have come up with that idea. I'm curious where the idea originally came from and who began promulgating it, but it certainly makes sense. The problem is we just really haven't ever determined that you can, through manual therapy, at least a reasonable type of manual therapy, give enough pressure to an area to cause a backflow of blood that would be so strong that it would cause valve damage or do the other potentially damaging things that we've always been told it would.
So I do want to add a really strong caveat to that, and that is in a situation where a client on the legs, on the lower extremity, where a person already has varicosities, or if a person is pregnant or has any other kind of physical obstruction going, it would be really a terrible idea to challenge the most superficial blood flow. But I'm just really curious. For instance, I have worked and heard people talk about working with folks who have multiple sclerosis, who for whatever reason, and I don't know the sequelae or the rationale behind this, they really love having pressure go down toward their hands. And that sort of goes against all of our training, and I don't know where that comes from or why that's necessary. So I just
Yeah.
want to clarify, I am not saying it's impossible to damage veins. That is not what I'm saying.
Yeah.
But I think there are times when we can push back on some of our folklore.
And I think what you're really highlighting there is the issue of how important clinical reasoning and critical thinking is in the decision-making process, because we're not trying to make a blanket statement about don't ever do this, but what are the circumstances under which you're doing that would make it either appropriate or inappropriate.
Right. Thank you. And that's such an important part. And part of critical thinking is challenging your assumptions, right?
Yeah.
Is what am I assuming when I'm making this decision, and is that really accurate? Another example of this is, that we must always do clockwise effleurage when we work on the belly, because that's the direction of flow in the colon. And
unless
I'm
you're
sorry.
working on people below the equator, then it goes in the other direction.
No, I don't think that's probably true.
Really? That's what I was taught.
But it's one of those traditions that I think is probably overstated, or when we're doing tapotement and how you have to lighten up over the kidneys.
Yeah, right.
The kidneys are under the lumbodorsal fascia and under the quadratus lumborum and halfway under the ribs, and really is your tapotement going to make someone pee blood? If that is the case, your tapotement is too hard.
Yeah, and they got a lot worse problems they need to be dealing with too.
Yeah. So I would love for people to look at the common wisdom or the tradition of our oral traditions of endangerments and ask, is that really true?
Yeah.
Yeah. So I love having this chat with you, and I want to just finish with a fragment of another conversation that I had. So, you work with Till Lukow on your wonderful podcast, The Thinking Practitioner.
Mm-hmm.
And I was hoping to have a conversation with Till on this topic, and he ended up not being available. But he's actually the one who provided my title for the feature article, "Taking the Danger Out of Endangerment Sites." And the little fragment that I got out of our abbreviated email conversation was his sense that endangerment sites are overstated, and that, again, as a continuing education provider in advanced bodywork techniques, he's having to unteach a lot of people's or deal with a lot of people's apprehension and fear and assumptions that no, you can't work in the neck, and no, you can't work in the axilla, and no, you can't work on the medial thigh. And so, I think maybe on the spectrum, he would come down, I'm speaking for him here, which may not be fair, but he might come down on the side that we teach too much fear about endangerment sites. What's your take on that?
Again, to me, this comes back to the issue of relativism, because I think it has a lot to do with where you're working and what you're doing. Because that may be true, for example, if you're working in, let's say, a private practice situation, and you're working to the large extent with people who are relatively healthy and wanting to do some things. Maybe they got some back pain, some neck pain, but no major things going on. I spent a number of years working in an orthopedic clinic, dealing with some pretty serious injuries, conditions, and people who had pretty serious damage in a lot of places. And there were a lot of endangerments that would be normal for most everybody else,
right,
under those circumstances. So I think it's a relativistic issue that's highly dependent on what you're doing, where you're working, and who you are working with in terms of how important a lot of those things are. So this is, again, we keep hearing a lot in sort of the educational communities about we need to teach more critical thinking skills to our students, and this is exactly why.
Yeah.
Because you can't really make those kind of blanket statements about endangerments in general. I don't think just because there's too much that's different in some of these different types of environments.
Yeah, a gazillion different variables that weigh in, but we have to start with some baseline knowledge.
Yeah.
Good. Well, and so that's what in this issue I've tried to do in the feature article, which is taking the danger out of endangerment sites. And then in my Pathology Perspectives article, it will be just a synopsis of what has turned up in the medical literature about demonstrated cases, or possibly demonstrated cases where massage therapists have caused some injuries. So,
yeah. Mm-hmm.
But I love your take on this, that we start with some baseline information, and from there we use that to do some clinical reasoning and some critical thinking to make the best choices for our clients. So.
Yeah, I think those things are really important, and they do emphasize how important it is for people not to get attached to these sort of recipe and routine models of what we do, but really think critically about each unique situation and each unique individual, because they're all different.
Yeah, I agree. Hey, Whitney, thank you so much for your time today. I think this is going to be a great thing to add to the article.
Well, thanks so much. It's great to always talk with you, and I'm glad to be able to contribute some to it.
All right. See you next time.
Okay, take care.